appreciate this group. I'm excited that we have so many people within the community of Fort Wayne that are coming together with really fantastic programs, and then having meetings like this where we can intertwine our programs into something that starts to create a system of care. And we have this on multiple levels. The prenatal group is a really important part of that, and I just appreciate the chance to be part of it here. We have this facility we are using as the Fort Wayne Medical Education Program. It's a family medicine residency program. We have 30 family medicine residents, which is 10 for each year of training, for 3-year training. So after the students graduate from college, go to medical school, graduate from medical school, then if they want to become family medicine doctors, they spend 3 years here. In this program, when they graduate, then they can become board certified family medicine doctors and hopefully hired in our community. There are 6 full-time physician faculty as well as additional faculty, and Dr. Nate Stuckey is one of our pharmacist faculty member. We also have faculty in behavioral health. If I'd been organized, I would have had them give this presentation today, but I wasn't, so I'm giving it. We have 2 faculty members in behavioral health. Then we also have another member who's a social service, provides social services. So today I'm going to just discuss, you have in front of you the PHQ-9 as a tool and the GAD-7. So I must say I'm very grateful for the internet for giving me these photos this morning. So we can't really publish these online. I might give you just a blank one to put online. But we know that depression and anxiety are really important mood disorders that can occur during pregnancy and after pregnancy, affecting both the birth outcome and the outcome for the children that are being raised. So about 13% of mothers experience depression during or after pregnancy. And certain risk factors can increase their risk of depression during or after pregnancy, such as a personal history of depression or another mental illness, a family history of depression or other mental illness, a lack of support from family and friends, anxiety or negative feelings about the pregnancy, problems with a previous pregnancy or birth, marriage or money problems, stressful life events, young age, substance abuse. The USPSTF, you probably don't know that, the United States Preventative Services Task Force recommends screening for depression during and after pregnancy, regardless of the woman's risk factors. The tool that we use to screen for depression most commonly is the PHQ-9, and that's the patient health questionnaire with 9 questions. Interestingly, the first 2 questions of the PHQ-9 can be used by themselves to have a pretty good detection rate for depression. So if you're using the tool to just see if someone you're suspecting has depression, or if you want to screen everyone for depression and refer those that you're finding probably need to be referred, you can actually just use the first 2 questions on that, on both the PHQ-9 and the GAD-7 for anxiety. So if we look a little closer, the first questions here, the time frame that you're answering for is really just the last 2 weeks for the person. So over the last 2 weeks, have you had little interest or pleasure in doing things? Not at all, several days, more than half the days, nearly every day. So each of those will have a point in severity from 1 to 3. It's a fairly straightforward questionnaire, really. And then the next question, feeling down, depressed, or hopeless, again, scored in the same way. If you're using just the 2 questions for a brief depression questionnaire, then it would be a yes or a no for either of those. So if you're getting yes on both, then you probably want to do a referral or do the full questionnaire and see how they score. It also asks about trouble falling asleep, feeling tired or having little energy. They're starting to ask about the somatic effects of depression. So sometimes we have depression that's not just the mood. Very often it also is disrupting sleep, disrupting appetite, disrupting just your general energy level. it also causes just some self-analysis that's very negative, some very negative self-talk, feeling bad about yourself, feeling like you're a failure, that you'd let yourself or your family down. Disturbs your ability to concentrate. Often, I find that people will complain about memory loss. It's like they're 24 years old and they're afraid they have dementia, right? And they're saying, oh, I have such a bad memory. If I'm finding that in the face of depression, then often it's just because if you're not concentrating on the information that's coming into your brain, it's not in there to pull back out again. So if they weren't paying attention to the things that were just presented to them, they won't be able to recall it. Also, along with depression, we often see issues with word finding, or sometimes even the antidepressants will cause issues with word finding. You know what you want to say, but you fish around for the exact word to use before you spit it out. People will be concerned that they have memory loss with that also, that can be either from the depression or actually from the antidepressant itself. Moving or speaking so slowly that other people could have noticed, or the opposite, being so fidgety and restless that you've been moving around a lot more than usual. I just find it interesting. When I first was learning about depression, or when I was first experiencing it, I was just really shocked at how integrated our brain and those little chemicals in our brain are with the entire rest of our body. And you may notice when you have clients that are depressed that they can barely get out of bed. They're not showering very often. They're not taking care of themselves. And one thing I would notice when they have, has everybody had a client who is extremely depressed and just could barely get out of bed, was showering like once a week? You're afraid they were neglecting their children because of their depression? When it's that severe, I would really be suspicious that they could have a severe depression, but they may also have a different psychiatric disorder. It may be bipolar disorder or schizophrenia or schizoaffective disorder. And it would really be vigilant to make sure that they get fully worked up by either family medicine doctor, psychiatrist, or their gynecologist if that person is familiar with behavioral science issues. So the last item on there also, let me go ahead and move to the next. Thoughts that you would be better off dead or hurting yourself. We know when people are profoundly depressed, it's a miserable state. And many people will just feel like if they could just get some relief, like they don't know how they're going to go through another 24 hours feeling like that. In my personal experience, the majority of people with profound depression feel like they just need relief. If they could just, if they were just dead, it would all be over. And they're not really indicating that they're intending to hurt themselves. And I don't expect you to be able to make a distinction between feeling someone who is actively suicidal and someone who is better off dead. Just just feeling that they would have some relief if they could just die and be still and be done with it. But there are two different things that could be. So not everyone who expresses that they would feel that they were better off dead actually is actively suicidal. But all of those people would need to be evaluated comprehensively. So once you go through the whole questionnaire, then you would just score up each of the columns and then add the columns together, and that will give you a single score. So if the person you're suspicious that they have depression, or maybe you just did some screening, 0 to 4 would be pretty much not depression. 5 to 9, it might be something else, or it could be depression. You might see this just with a stressful life event and a very temporary time. Something happened. We're just asking about the last 2 weeks. Something happened in the last couple of weeks. And so we want to be vigilant about that. Watchful waiting would be appropriate, touching base with that person in a week or two and see if this situation has passed or if they're the same or getting worse and would need a further evaluation. 10 to 14, watchful waiting. Really, by the time we hit 15, when it's mild depression, watchful waiting is fine. It's also really appropriate to start talking to them about ways to manage stress. getting them referred to a counselor who can start to find out what the issues are going on in that person, what their coping skills are that they're bringing to the table, or what they might also benefit from. But you don't have to start medication. You can, but medication and counseling are both equally effective at that stage. If you get a little more severe, moderate, we really recommend treatment with either psychotherapy or medication, and then by the time you get to severe, often we're using both. My personal preference is that as soon as we discover any issues, I really like to refer into counseling and then add medication as needed. There's not a whole lot of with our kind of deficit in mental health care in Allen County, I'm finding that the patients that I have don't have a lot of baseline understanding of healthy behaviors and healthy coping skills, and often they're coming from a deficit. So I like to engage behavioral health counseling really early in the process, as soon as I'm aware that maybe there's not depression, maybe there's just a lot of dysfunction in the family or in their environment, to really start teaching them some healthy behaviors and healthy mental health behaviors before their coping skills are overwhelmed. Any questions about the PHQ-9? How often should it be done? Yes.
What do you think is better? This or the Edinburgh?
The Edinburgh is specific for postpartum and has the best data postpartum, better than the PHQ-9. So the Edinburgh had predictive data. If you get a certain score on the Edinburgh Depression Scale at 6 weeks postpartum, then that predicts having a problem with depression, and the action points are very specific. It was not really developed for during the pregnancy or at other times. So this one can be used on both the mothers and the fathers and other family members that are around. It's not great with children, but for adults, it's been validated.
It would be either used
during pregnancy, anytime.
And now the Edinburgh.
They're probably both fantastic. Just looking for mental health issues and depression during pregnancy is great. Having an eye out for it, catching dysfunctional coping mechanisms that just disrupt relationships and stability. All of those things are good, and it's just really which one has better data for predicting who's going to have bad consequences from the depression. So if you're familiar with the Edinburgh and like to use that, keep using it. The PHQ-9 is one of the quality measures that Medicare looks for and Medicaid, and they'll actually deliberately track that for each adult. So if you're involved in an institution where you've got value reimbursement, things you may be asked to do the PHQ-9. So how often should it be done? When we're treating a patient for depression, then as providers, we'll go ahead and evaluate the patient with the PHQ-9 or something similar about once a month until the patient is in remission. And then every 3 months while the patient's still on treatment. And then once a year for people that have a history of depression who are no longer on active treatment. Those would be the guidelines, yeah.
Do you have any data on a more at-risk population that we represent in terms of
what rate they'll have the depression?
Women having more than, say, a normal?
Logically, it would be higher, and I think in some studies it is. I don't think there's also a counterbalancing effect, though, of it's a population that has more resilience than other populations, so I don't know that the actual number is higher. But there have been studies that showed both. Mm-hmm.
I know you said this is for 2 weeks and under, but do you ever ask, especially if it's a high score, how long they have felt
Absolutely.
This way? And does that make a predictor whether they're more possibly like suicidal as opposed to being, I'm not medical, but it just, I just wonder why it's only 2 weeks.
2 weeks. The 2 week time frame is just to have a benchmark so that they can show some validity for the test itself. So they try to eliminate all the variables while they're studying the questionnaire to see if it would have a statistical predictive value. So they've limited for the symptoms that are 2 weeks prior. But it's very, very important to take the person's whole history and find out if they've had depression. You know, for many times they've been hospitalized with bipolar disorder or, you know, school disruption or attention deficit disorder and all the other things that could be factoring into their current state. Yeah.
Do you find that if somebody has a higher score that they're often, or that they're surprised by a diagnosis of depression? I mean, do they just think this is...
I think people are surprised at how severe their depression is. I think by the time most people recognize that they're depressed at all, they're already moderate or severe. And they're, in their mind, they're thinking, maybe I'm depressed or maybe I'm not. You know, my friend went through worse, so who am I to be not able to handle what I'm going through right now? And I think people very much tend to understate their symptoms. And it's helpful for them to see what it would score out to be so that they can recognize it's a legitimate point to stop and go get some assistance. Because otherwise people really minimize things. That's been my experience. I'm not recalling any time where someone has been exaggerating their depression symptoms and then scored out lower. It's always been the other way. Anybody else? Yeah.
Would there be any downside to more frequent screening, particularly in non-bipolar?
I don't think there would be. There are so many social and hormonal changes happening during pregnancy. I think especially using something quick like the PHQ-2, just the first 2 questions, they're easy. They're actually really easy conversation starters. Have you lost interest in your activities? Are you still enjoying, or phrase it positively, have you been enjoying your activities? What are you involved with now? Feeling down, depressed, or hopeless, just what's your mood been? Can you describe it? Those are pretty natural conversation starters, I think. Easy to incorporate. So, anxieties have anxieties. Poor Charlie Brown. Up to 17% of women can experience anxiety in pregnancy in the postpartum period. Actually, that was both. Yeah, that was anxiety. And then almost 5% were also diagnosed with depression. I've lost my cursor. Come back. Where are the rest of my notes? So anyway, for screening for anxiety, we actually use the GAD-7, which is the Generalized Anxiety Disorder 7-item scale. Like we said, just like the PHQ-9, the first 2 questions are also good for just a briefer screening if you're wanting to do that. So over the last 2 weeks, again, the same time frame, how often have you been bothered by the following problems? Feeling nervous, anxious, or on edge? Not able to stop or control worrying? Worrying too much about different things? Trouble relaxing? Being so restless that it's hard to sit still? Becoming easily annoyed or irritable? This one, the 6th one, I see more commonly in men. They sometimes will complain about feeling anxious. Often they'll talk about, man, I just snap at the drop of a hat. And then I ask some more specifically about anxiety. Or feeling afraid as if something awful might happen, just that sense of dread. So scoring each of the columns in the same way we did the PHQ-9. 10 is the cutoff that's accepted of anxiety or no anxiety. Although lower than 10 might indicate mild anxiety, most people with mild anxiety are thinking that they can handle it. They're just looking for a little advice, is how people usually present that to me, their own analysis of their symptoms. Moderate anxiety, severe anxiety would really need some further workup or medications to help treat those. So, any questions about the GAD-7 and its scoring? Can you guys think of how you might use it with your own clients? What we like to do in the practice is sometimes do the full PHQ-9 or the full GAD-7, and then at other times just use the first 2 questions to kind of see if there's anything new coming out. So, thank you.